Welcome everybody to the video. We're so glad you're joining us. Today, we're going to be discussing the advantages of the patient-centered medical home and specialty practice model. So today I'm joined by my colleague, Vicky Hardin. She and I are on the REC PCMH and PCSP team, and we help practices achieve recognition. And so we're excited about speaking about those advantages today with you. So just to give you a little bit about what is PCMH, really it's a model of care. It's not a location, and it helps build infrastructure and a foundation for that quadruple aim and achieving value-based care requirements. It really helps practices with their patient preferences and create those lasting partnerships between that provider and patient and that clinic to have better patient satisfaction, improve quality, and help with care coordination and chronic disease management. So the programs for PCMH and PCSP are set up as a roadmap, and NCQA has done a really good job to help guide practices in order to become recognized practices with this model of care, and it helps them to be more comprehensive and patient-centered, better referrals and coordinated care efforts, having improved access and a safe environment. Now in the country, there's currently over 9,000 NCQA recognized PCMH or PCSP practices. And here in the state of Kentucky, we have about 186 practices that are recognized. Now, if you decide that you want to become recognized, what are some of the things that you have to do is one of the big questions we always get. Well, there are 6 different concept areas for the primary care or the patient-centered model home. And then for specialty, there's actually 7. So they're all the same, except for specialty does have that additional area of the initial referral management. So it's very heavily looking into that care coordination and that referral management between that initial referral to that specialty practice. So that's the biggest difference. Everybody, both programs really center on team-based approaches, how to know and manage your patients, access, and then care management, and then care coordination, and then quality improvement. Those are your big areas that you really have to work on towards recognition. So when you think about value-based care, what is that? Aetna actually had a really good article that they describe what is value-based care. And it's really how clinicians and organizations are paid based off health outcomes and really the value and quality of their services. So it's not that fee-for-service model that we are used to in the previous years, but now it's really basing on your performance, and that quality and value ends up being after you take care of your patients. There's some potential for some financial incentives based upon financial risks that are involved with your different payers or insurance companies. So that really is part of that value-based care approach. Now, what are some things that are available as becoming value-based model? You're really going to see some healthcare savings and some different expenditures with this model. So you're going to find early detection of different addressing risk factors, some improved care with managed chronic conditions, your care coordination with informed referrals, your ER and hospital reductions, less duplicative tests, and some generic prescriptions that help with those cost savings as well. The New England Journal of Medicine actually said that one way to become a value-based care infrastructure or instill that infrastructure within your organization is by becoming recognized as a patient-centered medical home or a specialty practice, because that medical home has that structure that leads to that coordinated approach for patient care by that primary care physician and their team that really helps build the infrastructure necessary for value-based care. So by becoming a patient-centered medical home, NCQA did a survey a few years ago that really saw some health outcome benefits. And what they have found is several different clinical measure improvements. These are just a few of those that were found. And it just really shows across the country and multiple organizations with this recognition, what kind of improvements that were attained. And you can see there with different A1C, nephropathy, LDL, and diabetic eye exams. Some other benefits are related to the patient. And with this survey, NCQA determined that 73% of patients actually want this type of care. And 61% of patients feel like the patient-centered medical home actually improves their health, that type of model of care. And 83% of actual patients saw improvement in their health by being in this type of model. And also that access saw improvement by 51% rate of same-day appointments were occurring. So you have health benefits, patient benefits. There's also practice benefits that evolve from this model. And you can see the ER hospital reductions that I mentioned, that improved access to care, better preventive care, and then that higher patient engagement with their self-management that's really beneficial, especially in those chronic care conditions with those patients with comorbidities. You also see with the staff and the organization has seen improvement in those efficiencies with their practice, and the workflows really have helped a lot. That's one of the biggest benefits I think that practices notice by becoming recognized. This is consistency and their workflows and how much more efficient their practice becomes for themselves and their patients. So the biggest question, well, how's this going to help us with our money? How much financial advantage is involved with being patient-centered medical home? Well, the survey that NCQA did found that with health cost savings is really pretty great. There's increased office visits. They have lower acute care hospital spending of 62%, almost $1,100 lower and per patient total Medicare spending, a 9.3% reduction in ED utilization, which ended up helping in almost $5 million in savings a year, and then a 10.3% reduction in those ambulatory inpatient admissions with those patients with 2 or more comorbidities. So another benefit is with the quality payment program and that MIPS track. Most everyone submits or attests for the MIPS program every year. So one big benefit is by having recognition, you get full credit in that improvement activities category. It's automatic. It saves so much time as you're trying to save your documentation for that improvement activities for your group, because you get automatic full credit as long as you have at least 50% or more of your sites are recognized. So that's a really big benefit. Another very helpful thing is if you are a FQHC organization, you can go through HRSA, and HRSA, through that application, you can receive funding for that initial recognition and or renewal every year, and for any add-on sites that you do for your organization. It's very helpful financially for that FQHC and saves a lot of money for you. You just have to submit that notice of intent to see if you are awarded that. Now, I want to pass this on to my colleague, Vicky. She is going to talk about her experience as a former practice manager and how the REC helped them achieve their PCMH recognition. So, Vicky?
Thank you so much, Vance. So let's do a definition of a practice manager. Practice manager performs many leadership, organization, and decision-making tasks to maintain and grow the medical practice they work for. It's a really good definition. And practice managers are some of your best leaders in the organization. So a practice manager's job description can consist of many tasks that are reflected above. You wear many, many hats. And these tasks are related to quality improvement, IT compliance, human resources, operations. And by no means does the above task reflect everything you do in a day. That would take several slides. But I wanted to highlight some of the tasks that align with PCMH standards and guidelines. So in 2015, I accepted a position with NCQA, and the expectation of my job was for the practice to become PCMH recognized in 18 months. Okay, which was a little overwhelming for me because I was new to the position, and I had found that the practice had only started. They had not really even started the process. But fortunately for me, there was an agreement signed between the Kentucky REC and the FQHC that I would be assisted by a REC advisor, an expert, a PCMH expert, and she would guide and assist me through the process, which was wonderful. And I'm just going to tell you a little bit about what she did for me. We downloaded the standards and guidelines, and we went through each measure, and we dissected the measure. We discussed what if the practice was, did the workflow process exist? If not, then how can we change it or tweak it, or what do we need to do to meet that measure, to meet that full point measure? Then we made sure that there was documentation in place to prove that we were doing it. And then the third step was, can we extract data if needed, or can we show a policy to show that we are that is in place? So those were the three steps that we focused on for each measure, and she was right there with me through each measure. She gave me the resources that I needed. She gave me policy templates, which was a huge help. She kind of sometimes defined the measures for me in layman terms, because sometimes it was a little bit hard for me to understand exactly what they were wanting. So she was always there with any answer to my questions. And I definitely know that without her, I would not have been able to help the practice to become recognized within the 18 months that was set before me. But with her help, we actually was recognized within 15 months, which was a huge accomplishment for our practice. And we was recognized at a level 3 criteria. So that was even better news for us. And I definitely could have not done that without our advisor. But what I do want you to remember that your clinical team, their total focus is on patient outcomes. And sometimes they need a leader to step up, especially in a project such as patient-centered medical home, to step up and lead them through this process. And as overwhelming as it is, practice managers, quality directors, nursing managers, office managers, sometimes they are the leaders. So when your day is really overwhelming and you really have way too much to do, just remember you are an amazing leader and you're going to lead your practice to success. Thank you so much.
Well, thanks, Vicky, for that insight. That is very good to hear your side of the story as a practice manager and how the REC kind of helped do that. And so if you're thinking about, is our organization ready for PCMH or PCSP? We have a readiness assessment. It's very short. It's very brief. There's no obligation if you do go to the link and you do it. It's 3 or 4, maybe 5 questions. We'll evaluate that and give you an assessment to just kind of talk to you to let you know, are you ready for this? Or how close you are, what kind of things you might need to work on before you want to get started. Feel free to contact us, and we'll lead you where that assessment can be found. Like Vicky was saying, we do offer personalized support for practices that are wanting to achieve this recognition. I am a certified expert in certified content expert with PCMH. We provide gap analysis, education, and help you as you submit for your initial recognition and or your annual renewal. We have helped over 135 practices to achieve recognition, and out of those that have submitted for recognition, every single one of them have achieved recognition. So we're really proud of that. If you have questions, please contact us. You can see our phone number, our email, and our website address, or you can contact us. We're also on Facebook, Twitter, and LinkedIn. We really look forward to talking to you and hope we answered some questions that you may have about PCMH or PCSP. If not, please contact us and we'll be glad to give you further details. Thanks so much.